Welcome to the ASCO e-learning weekly podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complementary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hello, my name's Alex Menzies, a medical oncologist from Melanoma Institute Australia. Today I'll be talking about the Stage 4 melanoma consult in 2019, what biomarkers and treatments are appropriate in the frontline setting, and is there one answer to correct frontline therapy? To do so, I'm going to start with two cases, and these patients are quite different in both their medical background, disease characteristics, and the treatment setting. Firstly, Stephen. He presents to a metropolitan large melanoma unit. Stephen's 30 years old, with no past medical history or melanoma history, that presents with symptomatic brain metastases. He has a large symptomatic metastasis that's resected and 4 asymptomatic brain metastases. His melanoma is BRAF mutant, and he has low volume extracranial disease with 3 sub-centimetre lung metastases only. In contrast, James lives in a regional centre. James presents to a general oncology clinic, and he's 70 with a past history of desmoplastic melanoma. He has chronic renal failure in the setting of diabetes, as well as polymyalgia rheumatica, for which he needs low-dose prednisone. James presents with a cough and is found to have up to 20 lung metastases, the largest 2 centimetres in size, as well as a single liver metastasis. As you can see, both these cases are quite different, and they highlight 3 broad areas that one must consider when planning treatment. Firstly, you need to understand the patient and their comorbidities. Secondly, the melanoma disease and the characteristics of this. And finally, the clinical context in which these patients are being treated. Firstly, the patient. When approaching a patient with melanoma, you need to know their past medical history, particularly including any history of autoimmune disease, immunosuppression, or concurrent medications that may interact with either targeted therapy or diminish or alter the effectiveness of immunotherapy. Furthermore, you need to understand the patient's ability to take medication appropriately, report any side effects, and, should they develop toxicity, handle emergent toxicity. For example, a patient with severe autoimmune disease may not be appropriate for immunotherapy. On the other hand, a patient with cognitive impairment may not be able to receive targeted therapy and administer this in a regular fashion appropriately. The next important thing is to consider the disease, and this is where there are a number of factors that need to be considered. While there are no routine molecular biomarkers that are used in the clinical setting apart from the BRAF status, there are a number of other factors that we use to decide treatment. Firstly, of course, is BRAF status, and if patients have BRAF mutant melanoma, targeted therapy is an option. Beyond this though, the primary melanoma subtype, for example mucosal melanoma, which is generally BRAF wild type and responds poorly to single agent PD-1, which may be more appropriate for combination, immunotherapy, or desmoplastic melanoma that has a very high tumour mutation burden and responds well to single agent PD-1, are things you need to consider. Other factors that suggest more aggressive disease that would indicate more aggressive treatment, for example, combination therapy over single agent immunotherapy, include the presence of brain metastases, liver metastases, or an elevated LDH. There has been a lot of discussion regarding the role of PD-L1 testing in melanoma and cancer in general. Unlike in lung cancer, for example, PD-L1 testing has not become routine in melanoma. This is because patients with PD-L1 negative tumours can still respond to PD-1 therapy, and there is significant heterogeneity of PD-L1 expression. While this test is not routinely performed in most centres, it may be a factor, among others, that direct the type of immunotherapy treatment used. Regarding BRAF mutant melanoma, In terms of disease characteristics that may select for targeted therapy over immunotherapy, I would generally reserve targeted therapy for people with high volume, rapidly growing symptomatic disease where patients require prompt improvement of symptoms and that cannot wait for immunotherapy to work or risk immunotherapy not working. In this situation, targeted therapy treatment alone is almost always palliative treatment, extending survival by a few months. And due to this, coupled with the potential benefit of long-term control with immunotherapy, but by no means guaranteed, I generally treat people briefly with targeted therapy before switching them on to immunotherapy once symptoms are settled after a few weeks. For the vast majority of people, however, I'm thinking of immunotherapy treatment, with the main decision being targeted single-agent PD-1 therapy versus combination therapy. As mentioned before, the main things I would consider when thinking about combination therapy are the disease characteristics of BRAF mutant melanoma, a mucosal subtype, brain metastases, and an elevated LDH, for example. Clearly, if we're giving combination immunotherapy to a patient, we also need to consider their comorbidities, particularly the ability to handle any toxicities that may emerge, such as colitis or hepatitis, and how they may react to the addition of steroids to manage these. Another important thing we consider is our clinical context. Doctors that see hundreds of melanoma patients a year and work in a large melanoma centre with a large clinical team that can provide supportive care to patients, as well as a subspecialty network to manage toxicities, these clinicians are more suitable to be able to use combination immunotherapy in a safer manner. On the other hand, clinicians that don't see many melanoma patients, or have patients that live remotely from the unit, or the unit is quite small with limited support, these clinicians may be better off considering PD-1 monotherapy for the vast majority of patients, simply to ensure appropriate delivery of care in the best context possible. So as you can see, there are a number of factors that we have to consider when determining treatment in the frontline setting for patients with melanoma. Both the patient and their comorbidities, the disease itself, as well as the clinical context in which the patient's being treated. For the vast majority of patients with metastatic melanoma, immunotherapy is standard care and is the first-line treatment. This is clearly so for those with BRAF wild-type melanoma, but even for most patients with BRAF mutant melanoma, we're considering immunotherapy for these patients unless highly symptomatic and needing a rapid improvement of symptoms. Within immunotherapy, the choice of single agent or combination therapy is difficult, and clinicians often agonise over one treatment over the other. Both looking at the patient, the disease factors, and the clinical context, as well as coupling efficacy and toxicity issues and discussing this with the patient are critical to ensure best practice. As you can see, there is no one answer to correct frontline therapy in melanoma in 2019, and it is a decision between the clinician, their patient, and their carers and family to provide best care. I hope you found this podcast informative, and thank you for listening to this week's episode of the ASCO e-learning weekly podcast. For more information on the treatment of melanoma, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive e-learning centre at elearning.asco.org. Thank you.
Thank you for listening to this week's episode of the ASCO e-learning weekly podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive e-learning center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.